Good morning, everyone. My name is Daniela Michel, and I will be talking today about educational engagement strategies for the implementation of a hepatitis C program at the Dr. Peters Center. That looks good. So my practicum was at the Dr. Peters Center from January to early April, and the Dr. Peters Center provides care and support services to people living with HIV and with additional health and social vulnerabilities. I will be referring to the Dr. Peters Center as the DPC throughout the presentation. My practicum placement was in a knowledge translation and evaluation team, which works collaboratively with other teams at the DPC to share the model of care with external collaborators and facilitates communication between service providers, policymakers, and knowledge networks. When I started my practicum, the DPC was planning to launch a hepatitis C support program with the goals to provide participants increased access to health information and support in the medical management of hepatitis C. The center was interested in an evidence base to build a hepatitis C support program to educate, engage, and support their clients. Hepatitis C, or HCV for short, is a major public health concern. In Canada, chronic HCV is a leading cause for liver transplants due to liver cancers or cirrhosis. Prevalence is highest among baby boomers and people who inject drugs. Marginalized populations, such as people who inject drugs, or those suffering from co-infections, such as HIV/AIDS, are a major risk group for HCV. Thanks to recent advances in treatment, HCV is curable with cure rates of up to 97%. This is a graph showing the HCV cascade of care in BC. It highlights points across the continuum where people fall through the cracks for a variety of reasons. A major gap exists from those confirmed with HCV, which is the middle column, the dark teal portion, and shows nearly 31,000 people with confirmed HCV. And out of those, only 8,500 went on to start treatment. So clearly, there are a number of significant barriers that prevent people from initiating HCV treatment. So these are some of the barriers associated with treatment access and uptake. One of the most important barriers is that HCV is a stigmatizing disease due to the high prevalence of drug users, high prevalence of HCV in drug users. It can lead to discrimination, and people are afraid to disclose their status. Other barriers include the silent progression of HCV and the lack of symptoms, often for decades, and this removes any urgency to seek treatment. Previous treatments had severe side effects, and many people know other people who have gone through treatment and have experienced some of these side effects, and now they exhibit a fear of treatment. Marginalized populations are a high-risk group, and competing priorities such as other health, work, or social needs, and unstable and chaotic lifestyle have also been identified as considerable barriers to treatment. In addition, there continue to be biases against people who use drugs, and some physicians may have concerns about treatment adherences or comorbidities and refrain from prescribing treatment. On a system level, access to care and the navigation of a highly compartmentalized healthcare system presents additional barriers. One large barrier was removed by the province of BC last year, which is pharmacare coverage for all BC residents for HCV treatment. Structural factors such as housing, poverty, the criminalization of drugs, among many others, also play a significant role, but these were outside the scope of this paper. So the key objective of the literature review was to assess evidence-based public health educational and engagement strategies in a community-based setting for the implementation of the HCV support program at the DPC with the goal to increase treatment uptake and adherence rates. So the databases searched were CINAHL, Web of Science, PsycInfo, and PubMed. The search strategy was limited to original research and case study articles in peer-reviewed journals in English and published between January 2000 and February 2019. Following the screening process, 28 articles were included in the literature review. Early in the literature synthesis, it became apparent that community-based HCV programs' educational strategies can broadly be divided in two main categories. The goal is either to increase knowledge or increase engagement in HCV care. With the goal to increase knowledge, evidence suggests that simple educational interventions, for example in the form of PowerPoint lectures, have proven to be successful in increasing knowledge. Facilitated, interactive educational events demonstrated a significantly greater potential to increase knowledge. And repetition is key for knowledge retention. As previously shown, once an HCV diagnosis is made, frequently treatment is not initiated. Engaging the patients is an essential cornerstone of any HCV program. Engagement strategies are more complex than interventions aimed at increasing knowledge, and evidence suggests that a combination of strategies is needed to increase patient engagement. Based on the findings, the creation of a support group is a key component. Research suggests that a strong group cohesion allows participants to form meaningful relationships and increased engagement. Support groups also provide a platform to repeat the educational sessions on a regular basis, in addition to supporting participants throughout the treatment and follow-up period. It is also recommended to include peers who have successfully completed treatment as part of the HCV support strategy. Evidence also suggests that peer workers can be helpful in reducing the stigma associated with HCV and with addressing concerns related to HCV and its treatment. In addition, flexible and low-barrier access to care in a culturally safe environment, as well as one-on-one case management and crisis support, are important elements of patient-centered engagement strategies. One-stop shop approaches allow for the whole continuum of care to be managed in one place and can improve gaps in care. Long-term, even if HCV is cured, reinfections are possible, and some clients may require lifelong monitoring of sustained liver damage, and thus long-term engagement is essential. Other important program considerations are listed here. Adding another service to a community-based healthcare facility is time and resource intensive, and it requires capacity and skill building. Provider, staff, and peer education are essential to fully utilize everyone's skill sets. The implementation of an evaluation strategy can ensure that the program meets its goals and can be adjusted as needed. In addition, advocacy to destigmatize, as well as advocacy on behalf of individuals, are other important components that need to be part of an HCV program in a community-based setting. The DPC is an ideal position to make a positive and lasting impact on HCV in the community by building an HCV program based on these findings. The DPC already utilizes many of these engagement strategies and provides flexible and low-barrier access to care, as well as an interdisciplinary team to support participants long-term. The DPC can continue to be a positive example for engaging people who use drugs successfully in treatment and advocate for broader change. In addition, the DPC's commitment to harm reduction is a key element in breaking the cycle of HCV transmission. So in conclusion, an HCV program built on the components knowledge, engagement, training, and advocacy allows for a comprehensive design and gives the DPC the opportunity to address many of the previously identified barriers to treatment uptake and adherence. I would like to thank my supervisors, Megan and Carly especially, for all the help throughout the practicum, and especially with the development of this project. I'd also like to thank the DPC for a great learning opportunity, great practicum, and especially I'd like to thank Rosalind, Justina, and Patrick at the DPC. And I would also like to thank the faculty at UVic here, especially Kathy, Nigel, and Nathan, and Betty. Sorry, you're not on the slide, but thank you. And so this was the first day at the DPC when the Hepatitis C support program was launched. This was on March 14 for a screening. And yeah, on that note, any questions?
Now I'm on. There we go. That was great. Thank you, Daniela. And thank you for being the first, which is always hard. And I didn't give you a choice. I just said, you're going first. And I also want to say hi to the gang at the DPC if they happen to be online and watching. Haven't seen you guys in a while. Looking forward to seeing you at CAR. Any questions? Okay, I'm gonna run the mic. I get my 10,000 steps in this way today.
Thanks for your presentation, Daniela. I'm just wondering if you know of any support groups that are happening, or if this was the first one in BC, or if there are other ones in Canada that the support group would be modeled against?
Yes, there actually, so the literature there were quite a few programs that utilized the support group. So there was one, the Kool-Aid Clinic in Victoria was one example, Panther Health as well. They have a similar setup. Those were two of the case studies I found while I was doing the literature search. So they have a very comprehensive program with support groups as sort of the anchoring element of their programs.
Any other questions? No? All right. If not, then we'll say thank you to Danielle. Oh, did I miss one? Sorry. I did scan.
Hi, thanks for your presentation. I was wondering if you could just tell us a little bit more about this launch. I see these pictures have literature, testing, and I think that's an ultrasound looking at liver health, and it just seems really interesting, and maybe you had a chance to see some of your research in action, and if you can just tell us a bit more about it, that'd be great.
Yeah, for sure. So this was the first day, so this was the launch of the project. So what they did at the center was just advertise the event coming up with some little table cards, and it was specifically for the participants at the DPC. And the program, so people who enrolled, there was a little information desk, which is the top left area. So we had a couple people sitting there talking to the participants, informing them why are we doing it, what are we doing, and if they wanted, they could sign up. And then we had different stations set up. So the first stop was a little finger prick test. So it was just to quickly say if they've been exposed to HCV, yes or no. The second stop was a full blood draw, so that HCV could be confirmed. And then one stop there for the pictures, this is called a fibroscan. So this is a little mobile ultrasound unit to scan the liver and just assess for liver damage. And then we had set up a little room for giving the results to a little bit of counseling if needed. But the confirmatory tests, they take 2 weeks. So this was just an initial kind of screening for HCV. And then, so these were all, they had to give consent that their information would be shared with their PCPs, and so that they could be supported in enrolling in treatment.
Mm-hmm. Wonderful. Thank you. It looks like it's going to be a great program. Anyway.
I think so, yeah.
So thank you, Daniela. And one more round of applause for Daniela. And I will ask Christina to move to the podium.